It's my pleasure to introduce Dr. Vijaya. In the morning I said in the inauguration that there is only one difference between men and women, that the women are better. In fact, Vijaya was my class fellow. We were 3 boys and she was the only girl, and she has done much better than all of us. She was always good. She has multiple gold medals from Guntur Medical College, and people from Guntur are generally very brilliant. There's something called Guntur gene. And then she did MD in General Medicine and got a silver medal in PGI Chandigarh 1987. I was with her in DM, and she was just amazing. And she started the first stroke unit in AP even before NIMS started stroke unit, and it was named after her. We were talking of compassion in the morning. It was started after her grandfather, because she had seen her grandfather suffering from stroke, and in his name she made the Ankinidu Stroke Center. And from that stroke center, much amazing work has been done in intravenous thrombolysis and intervention, which she has presented in national and international forums. And she has been awarded a gold medal from the World Stroke Organization for her work in this stroke. And she has a tremendous public awareness campaigns she has led in Guntur and adjoining areas. What's amazing is that she has her center, which she has created herself. You know, these days we talk of startup, but she has done that startup 30 years ago in Guntur. Today it is a recognized center for DM in neurology by national boards. So I really congratulate you. It is the only center for DNB neurology course in AP. And I think there is a lot to say, but there is not much time. So Vijaya, please go ahead.
Thank you, Dr. Kaul, respected chairpersons. And first I would like to thank Dr. Jyotsna Garu and her terrific team for starting and continuing such nice academic programs. It is a privilege for me to be here today. My talk is in stroke. It's though it is past lunchtime, I think it's very important to every one of us, because stroke is the leading cause of disability for anybody, and especially for women. And 1 in 6 people worldwide have stroke during their lifetime, and particularly women. More women have strokes than men. Women with stroke, as we know, receive less care like any other specialty than men, and they have worse recovery from stroke and more mortality and morbidity, and they have special risk factors in addition to the routine risk factors like pregnancy, puerperium, pills, HRT, and depression and migraine. These are extra risk factors in addition to those that they are in the men. And coming to the basic concepts, stroke is basically ischemic stroke 85% of the times, and hemorrhagic stroke. Ischemic stroke is the commonest, which can be because of thrombosis in situ or embolus from the heart commonly, and it can be a lacunar stroke. And the most important treatment today I'm discussing is about ischemic stroke. In ischemia, as we know, it's an ongoing process. Once there is a cutoff of the blood supply, there is a core where there is all the dead tissue, and there is a surrounding area called penumbra where there is still a viable tissue, and the collaterals which maintain that penumbra. The whole treatment of stroke is centered around saving that penumbra before irreversible damage occurs. And coming to the type of stroke, it is a very heterogeneous disease, and one treatment does not fit all. Interventional stroke therapy especially is useful in the large vessel disease. Cardioembolic stroke is a well-known entity where there is a lot of role for anticoagulants, and atrial fibrillation is one of the most common disease where primary prevention of stroke is present. And coming to the next concept, time is brain. As we know, stroke is a dynamic progressive disease with 2 million neurons dying every minute during stroke, and after 3 to 6 hours all the tissue is dead, and no treatment will be useful. Reperfusion is the most effective treatment known. And as we know, if you don't reperfuse the occluded vessel, progressively there will be damage and the patient will die ultimately. The most important concept is time is brain again. As we know, any treatment, if given early, like for example in 90 minutes, the golden hour in heart is little more in brain, like it is 1.5 hours is the best, but it can extend up to 6 or even 8 hours. That is the whole advantage of a stroke management. However, stroke is heterogeneous and time is brain, but each patient has his own time frame. It's not just the chronological window period, but also the physiological window period which matters. And many patients do remain stable below the critical line so that we can extend the stroke therapies much beyond the classic 4.5 hours. The standard of care is IV thrombolysis with TPA, which is not the point of discussion today. And after this, the classical trial of NINDS in 1995, this is the first evidence-based treatment in stroke. And this should be managed by a stroke team, which includes a cardiologist, of course, and many other specialties, including emergency physician and paramedical staff. However, there are many limitations of IVT. Therefore, for example, in patients with ICA blocks, it's only in 10% of the patients it is recanalized, and endovascular therapy of the stroke fills in this gap to potentially salvage these patients. What is the concept of endovascular therapy? This is where the vessel is blocked. In endovascular therapy or interventional therapy, we go all the way to this vessel and then give either drugs or use some mechanical retrievers to clear up that vessel to restore the flow. Therefore, the advantages are we are going directly to the disease site, and there is a direct assessment whether we are able to recanalize it or not by serially doing the angio. If it is not recanalized, we can add some more modalities. The opportunity to add mechanical thrombolysis in addition to the drugs, and there are higher recanalization rates in special situations like post-CABG if they have a stroke, or some post-surgery, either gynec or surgery if they have a stroke. We cannot give IV thrombolysis. This is the only way. This is one of our first cases way back in 2005. He came at a window period of 5 hours, and there is a complete occlusion of the MCA, as you can see. And after thrombolysis, this is the 100% occlusion. And after thrombolysis, we can recanalize this vessel to normalcy. And this patient lived for 8 years with minimal disability. This is another case where there is a young man with complete basilar occlusion. Routinely, the basilar strokes have 100% mortality, and this patient we could recanalize in time to save this patient, and he is normal till today. This is the first evidence study that showed us the role of intra-arterial thrombolysis in stroke. That is the PROACT-2 study. And a meta-analysis done in 2002 also showed significant benefit. However, we had to wait more than 15 years to confirm these results. And these are the evaluation of the studies that have started from 1999 to 2015, only after the addition of mechanical stent retrievers, which is an extension of cardiological treatments. Now the stroke has been treated successfully with significant benefit. These are all the studies that were published only in 2015, starting from MR Clean in Netherlands to Escape, Extend IA and Swift Prime from Canada. All these have unequivocally showed benefit with interventional therapy. So much so, some of them have been stopped prematurely because the benefit is so good in the treated patients. For example, in a study, as you can see, this is a Extend IA study outcome. Reperfusion at 24 hours in 37% for IV TPA, but at 100% in interventional therapy. The symptomatic hemorrhage is surprisingly very less, and the functional outcome is 71% versus 40%. In a serious and disabling disease like stroke, these outcomes are very, very encouraging, and there has been a lot of enthusiasm after the 2015 studies. What are the ways to do this interventional therapy? We can use either drugs alone, that is called pharmacological thrombolysis. We can use mechanical retrievers either alone or in combination with drugs. It started with Mercy, and now it is the era of stent retrievers like Solitaire and Trevo. We also use angioplasty and stenting just like in cardiology or any other peripheral vascular disease to open up these vessels. We presented one of the first few cases in this Euro-PCR by the cardiologist of our team. And this 80-year-old man, 2007 we treated this man with recurrent TIAs, and he had this, despite maximum medical therapy, he continued to have TIAs and this critical stenosis of the carotid. And then after angioplasty, balloon angioplasty and stenting, this is the balloon angioplasty, followed by complete restoration of the flow. This old man lived for 10 years, even 11 years, for 96 years of age. And the son came back just 2 days before I came here to tell me that he thought he will live till 100. But we fell down and had a fracture of neck of femur and died. So that was the good patient that was benefited. This is another case of lady with 46-year-old lady who came at 3 hours, but already she had infarct in the brain and he couldn't give IV TPA for this lady. Risk of hemorrhage was more. We took her up for angio, which showed 100%. Okay, this is the 100% block of the ICA. There is no collateral flow, and we could pass a guide wire across this occluded ICA, followed by balloon angioplasty, and then restoration of the flow. This lady recovered tremendously, and she remains normal till date with regular follow-ups. But what are the important issues? It's not as simple as the recanalization, we go and open up the vessel. It's very complicated. Stroke is a complicated disease and treatment are not straightforward. We have to have a proper imaging selection. We should have a proper workflow and infrastructure, and we should use proper technologies by experienced angiographers, and only then the outcomes will be good. Coming to our experience in interventional stroke therapy, we started our first stroke unit in Andhra Pradesh way back in 1997, and our interventional stroke therapy program we started from 2005. So far our total number of cases are about 232. And this is our first data which was published in International Stroke Journal. And as I can see, this is very important because Hyderabad, Dr. Kaul started the stroke program, and then he inspired and encouraged me to start a program in Guntur, and both of our centers are there in the world map at that time. We were so happy, and I always give the credit to Dr. Kaul for encouraging me and inspiring me and always to guide me even now. There are selection criteria for intra-arterial therapy. Beyond 4.5 hours or any contraindication for IV therapy. Age 18 to 80 years. NIH score more than 80. CT normal or less than 1/3 infarct. And these are all the several modalities we used to recanalize those arteries. Way back there was not much mechanical retrievers. Mercy was not available in India, and Penumbra was not accessible. It was very costly. We had to use other methods, and these are all the methods we used for these patients. And this data of the first 100 patients we presented in Vienna in 2008, where we showed at that time mechanical recanalization was very effective. Before the stent retrievers came, we showed by angioplasty and stenting, 92% of vessels we could recanalize when we used the mechanical methods of thrombolysis. Overall outcomes were not bad. More than 50% had good outcome. In a large strokes, it is significant. And very less hemorrhagic transformation or deaths. Example of a young man with a basilar stroke, where we could, after the drug, and this is the infarct. Though there are many infarcts, he recanalized and he became functionally normal. This is another case of interesting case of teacher in whom we had to use a very complicated type of recanalization techniques because they had tandem blocks, extracranial ICA, intracranial ICA, intracranial MCA. These are all the things that we had to open up one after other the arteries. This is the extracranial artery which we first opened up. Then in the intracranial ICA where there is a big clot, we had to lyse it with a drug, and then there was the MCA, which was 100% occlusion. And after the balloon angioplasty of the MCA, he recovered, and then this MRA post thrombolysis. This is 9 months follow-up, and this is he came last year 2015. Though he cannot teach because of the cognitive deficit, he is independent in his daily life. Recent case of acute stroke within 3.5 hours. We gave IV thrombolysis, and then because of suspicion of large vessel disease, we went ahead and did angio, where the angio showed 100% occlusion of the MCA with no collateral flow. This is a very fine balloon angioplasty done by our cardiologist of the team, and then followed by gentle balloon dilatation, and then this is the recanalization. Though he had infarct in the initial MRIs, and there is a good flow, there is a stenosis at the level of M1, M2. However, on day of discharge, he had this infarct have shrunken, and the patient is clinically normal except for minimal facial weakness. Another basilar stroke where we use the solitaire stent. This is a stent retriever which is used these days. Though it is a costly one, it is very useful for large vessel clots. This is the 100% occlusion of the basilar. The stent retriever goes all the way to the clot where you entrap the clot and then bring it out. This is the clot brought out. This is the in situ and this is the final result. This patient also improved nicely. The role of endovascular therapy and carotid stenting, it's a big topic by itself. However, in the case of TIAs, where he had recent TIA or a minor stroke with such critical stenosis in the ICA, either we can do surgery or stenting, but nowadays it is proven that it is non-inferior to surgical treatment, and depending on the center where the expertise is good, we can do carotid stenting, and this is the post-stenting, beautiful result. Again, because we are discussing the women's issues, CVT is a special thing. Though it can occur in men, it is more common in females, either postpartum or because of OC pills, where we have hemorrhagic infarcts and it is sometimes cannot give full dose heparin. You can go with local thrombolysis all the way to the sinus, this sagittal sinus, and after the drug urokinase infusion, totally recanalized. The last case, this is a very interesting case of peripheral vascular disease with posterior circulation TIAs. There is a 100% occlusion of the subclavian artery, and there was no flow to the vertebral, and the other side vertebral is rudimentary. Then what we did was we had to go retrograde from the radial to the opposite side, and we could put a balloon in the subclavian and then did a angioplasty followed by stent. This is the stenting of the subclavian artery, and then, however, after the subclavian is opened up, we saw that there is this origin of vertebral is also very much stenosed. Then the interventionist went ahead and did another angioplasty and stenting through this to the vertebral. This is the final result after the vertebral artery stenting, and the patient remained symptom free after that on double antiplatelets. Hence, the role of endovascular therapy has come to stay from the 2015, so much so that it has come to the guidelines very fast. Patients should receive endovascular therapy, class 1 level of evidence A, just like IV-TPA, if they meet the criteria. These are the criteria that should be met. And luckily, for a stroke, which there was no treatment when me and Dr. Kaul were doing DM, there was no treatment of stroke. And many people went to Ayurvedic or other local therapies. Even now they go. But however, luckily we have so many evidence-based therapies, starting from stroke unit to IV thrombolysis to decompressive craniectomy to all these interventional therapies of stroke. We are following in the footsteps of cardiologists, and with the help of cardiologists, neurologists are also gaining experience with these therapies, and many young neurologists these days are training both in neurology and interventions, and we have a good team, and there are good days ahead for treatment of stroke. The last take-home message I would like to say, stroke is a management of a continuum. It is never just one treatment that matters. We have to start from the home with pre-hospital care and very acute emergency care, just like in MI, without any complacence or loss of time. Acute therapies, including depending on the type of patient, and stroke unit care for each and every patient, and a good rehabilitation team. These are all that make difference for the stroke patient. Thank you.